Hello, this is Mrs. Castillo again. I'm working on part 3. We're going to start with glaucoma. The intraocular pressure, the IOP, is regulated by the formation and reabsorption of aqueous humor. Glaucoma is related to the balance and imbalance of the fluid, resulting in an elevation of IOP, which the inflow is more than the outflow, and the resulting consequences is optic nerve atrophy and peripheral visual field loss. Risk factors include high intraocular pressure, age, usually over the age of 60, and in African Americans, usually the age is over 40 is the risk factor. Family history of glaucoma, past injuries to the eye like retinal detachment, eye tumors, eye inflammation, and lens dislocation. History of severe blood loss or shock, poor circulation, or nearsightedness. Also medical conditions such as diabetes mellitus, hemodialysis, hypertension, and hypothyroidism are also risk factors. And long-term use of corticosteroid eye drops can also be a risk factor. Now there's primary open-angle glaucoma, which is 90% of glaucoma cases. It's the outflow of aqueous humor is decreased in the trabecular meshwork. Degenerative changes in the flow of aqueous humor results in an increased pressure on the structure of the eye and retina. Clinical manifestations are usually gradual visual loss. Sometimes there's no symptoms. It's unnoticed until all peripheral vision is lost. Primary angle closure glaucoma is about 10% of glaucoma cases. Clinical manifestations are sudden pain around the eye, nausea, vomiting, seeing colored halos around lights, blurred vision, ocular redness, corneal edema, and tunnel vision. Assessment usually is done with visual acuity, visual fields, IOP, and psychosocial reaction. A diagnostic test can be done obviously on history, a slit lamp examination, a tonometry measurement of IOP, a peripheral and central vision test, and a thalmoscopic scope could be done. Management of open angular glaucoma is usually done with drug therapy, and there's different types of drops, and the goal is to lower the pressure in the eye. And many of these drugs do the same thing in different ways. Beta-adrenergic receptor blocking agents, alpha-adrenergic agents, I'm so tired, I can't help it. Miotic agents, and usually these drugs, the miotics are prostaglandin drops, which increases the outflow of the fluid in the eye and it reduces pressure. Many of these drops are there to reduce the pressure in the eye. Surgical management can be laser. There can be some chirotherapy also done. Also, there could be a removal of the part of the iris and the trabecular meshwork. And these, of course, are all surgical management. Management of angle closure glaucoma is an ocular emergency requiring immediate care. Usually miotics are given and oral IV hyperosmotic agents, which can be oral glycerin or IV mannitol, and this decreases the IOP by increasing the blood osmolality, which causes osmotic pressure, which then draws water from the cavity. There can be a laser peripheral procedure or surgical procedure done, and what this does is it creates a small hole in the iris so that the fluid can flow through it and exit the eye. And remember, this is an emergency and this requires immediate care. Secondary glaucoma is managed by treating underlying problems and anti-glaucoma medications. Remember, your assessment includes assessing the patient's ability to understand and comply with the treatment, assessing patient's psychological reaction to sight-threatening disorder, assessing family for patient care, assessing visual acuity, visual fields, and IOP. Nursing diagnosis could be non-compliant, especially with these drops, and post-operatively, risk for injury, self-care deficits, and acute pain. Glaucoma expected outcomes is no further loss of vision, comply with recommended therapy, and safely function in the environment, and no pain from disease or surgery. Now we're going to move on to pain, and that's part of the final exam as well. Pain is whatever the experiencing person says it is, and it exists whenever he says it does. It is an unpleasant sensory and emotional experience in association with actual and potential tissue damage, or described in terms of such damage. Chronic pain, obviously, it's a cycle. And what it shows here on your slide is that chronic pain is an increased pain which causes anxiety, which causes sleeping problems, which causes non-coping behaviors. With chronic pain, there are many things that can bring it on, or can cause problems in your life, like worried about employment if you have chronic pain, general health worries, work coverage if you're in pain and if you can or can't go, medication worries if you can afford them or if you can take them, family and relationship worries, financial worries, doctor and hospital visits, anger and frustration, lack of employment. These all. Now, when we talk about neuropathic pain, it's different from muscle pain. Your doctor may refer to muscle pain as musculoskeletal or nociceptive pain. Neuropathic pain can feel like stabbing, burning, electrical shock feeling. Muscle pain often feels tender, achy, and stiff. Now, in children will respond to pain based on their age and developmental level. Note, children often are undertreated because of professional misconceptions or complexity of pain assessment, nonverbal, and lack of awareness. Old myths. Infants don't feel pain. Active children aren't in pain. These are all myths. Assessing previous experiences with pain and use appropriate assessment tools. Now, when you're studying for this part of the chapter, please look at all the different type of assessment tools that they use for the appropriate developmental age. Pain management, its detrimental effects of unrelieved pain, periventricular hemorrhage, psychosocial problems, cognitive deficits, poor motor performance, rise in somatic complaints. These are complaints that have no medical explanation. GI problems, heartburn, nausea, vomiting, migraines, backaches, and skin disorders are all somatic complaints. Long-term sequelae and physical symptoms. This is an abnormal condition that follows and is the result of disease treatment or injury, deafness from ototoxicity drugs, scar formation after a laceration. Also, we talk about treatment of phantom limb pain, and it's depending on where the amputation has taken place, of what type of symptoms the patient may feel as a treatment or a phantom limb pain. Some patients report a stabbing, a burning, a shooting, or a cramping feeling in that limb that was lost, and it is real to them, and we do treat this pain. Remember again that you need to use appropriate assessment tools, age-appropriate pain assessment tools, assessing previous experiences with pain, and children will respond to pain based on their age and developmental level. Keep this in mind. And thank you. That's the end of our neuro lecture.